If your doctor has recommended a nerve block for your sciatica pain, or if you are considering one because nothing else has worked, I need you to watch this video before you make any decision. Because what most seniors are not told before they walk into that procedure room is that nerve blocks for sciatica are not all the same. There are fundamentally different types with completely different mechanisms, completely different risks, completely different success rates, and completely different implications for your long-term nerve health. And the one your doctor is recommending may or may not be the right one for your specific type of sciatica. I have seen seniors go through multiple nerve block procedures that gave them temporary relief followed by worse pain than before, not because nerve blocks do not work, but because the wrong type was used for the wrong cause. I have also seen seniors decline nerve blocks out of fear and suffer needlessly for years when the right procedure could have given them significant and lasting relief. Today, I am going to give you everything you need to make an informed decision. What nerve blocks actually do inside your body, which types work best for which causes of sciatica, what the real risks are, and the critical questions you must ask your doctor before you ever agree to this procedure. Right now, thousands of seniors across America are receiving nerve block injections for sciatica pain every single week, and a significant percentage of them are walking out of those procedures without having been told 3 things that could completely change their decision. First, that the relief from most nerve blocks is temporary, lasting weeks to months, and that repeated injections carry cumulative risks that increase significantly with each procedure. Second, that the effectiveness of a nerve block depends entirely on correctly identifying the exact source and mechanism of your sciatica, and that without that correct diagnosis, a nerve block may provide zero relief while still exposing you to all of the risks. Third, that for certain types of sciatica, there are evidence-based, non-injection alternatives that produce comparable or superior long-term outcomes without any of the procedural risks. I am not telling you nerve blocks are wrong. For the right patient with the right diagnosis, they can be genuinely life-changing, but you deserve to walk into that decision with complete information. And today, I am giving you everything. My name is Dr. Michael Thompson, and I have spent over 22 years working with senior patients dealing with sciatica, spinal pain, and nerve conditions. In that time, I have guided hundreds of seniors through the decision of whether to pursue nerve block procedures, helping them understand what to expect, what questions to ask, and how to evaluate whether a specific procedure is truly appropriate for their specific situation. I have seen nerve blocks work beautifully when correctly indicated, and I have seen them fail, sometimes dramatically, when used without a precise diagnosis or when the wrong type was chosen for the wrong cause. Today, I am going to share everything I have learned so that you can walk into your next appointment as an informed patient who knows exactly what questions to ask and exactly what answers to listen for. Before I get into the specific types of nerve blocks, I want you to understand something fundamental about sciatica that most people, and unfortunately some doctors, oversimplify. Sciatica is not a diagnosis, it is a symptom. It is the name we give to pain that travels along the path of the sciatic nerve from the lower back, through the hip, down the leg, and sometimes all the way to the foot. But the cause of that pain can be any one of several completely different conditions. A herniated disc pressing on a nerve root, spinal stenosis narrowing the canal through which the nerve passes, piriformis syndrome where a muscle in the buttock compresses the nerve, sacroiliac joint dysfunction referring pain along the sciatic distribution, facet joint arthritis irritating the nerve root at the spinal level, or degenerative disc disease causing chronic inflammation around the nerve. Each of these causes requires a different treatment approach, and each responds to a different type of nerve block, or in some cases does not respond to nerve blocks at all. This is why the diagnostic precision before any nerve block procedure is so critically important. And this is why I want you to understand each type before you agree to any of them. If this is already giving you important information, please do me one quick favor right now. Hit that subscribe button and drop a comment below with your age in your city. I want to know how many seniors across America are facing this decision right now and need this kind of complete information before they proceed. I read every single comment, and your situation matters deeply to me. Now let me tell you about a patient of mine named Andy. He was 73 years old, a retired police officer from Michigan, one of the toughest and most straightforward men I have ever had the privilege of treating. Andy had been dealing with severe right-sided sciatica for almost 2 years by the time he came to my clinic. The pain ran from his lower right back all the way down through his buttock and into his calf. A deep burning, sometimes electric shooting pain that made it impossible for him to sit for more than 15 minutes at a time. He had been through 6 weeks of physical therapy with minimal improvement. He had tried 3 different pain medications, one of which caused such severe drowsiness that he had stopped driving. He had done 2 epidural steroid injections at a pain management clinic. The first had given him about 3 weeks of partial relief. The second had given him almost nothing. His pain management doctor was now recommending a 3rd epidural injection and had mentioned the possibility of radiofrequency ablation if injections continued to fail. When Andy came to me, he was frustrated in significant pain and deeply skeptical of any further procedures. He said, "Yeah, Dr. Michael, I feel like I am on a conveyor belt. They keep doing the same thing and it keeps not working, and nobody is stopping to ask why." And I said, "Andy, that is exactly the right question. Why is it not working?" Because the answer to that question is the most important piece of information in this entire situation. I reviewed Andy's MRI carefully, something that had apparently not been done in detail before his injections were performed. What I found was that Andy's primary sciatica generator was not a disc herniation, which is what epidural steroid injections are most effective for. Andy had significant sacroiliac joint dysfunction on the right side, combined with moderate piriformis muscle involvement. Neither of these structures is effectively treated by an epidural steroid injection. An epidural injection deposits medication into the epidural space around the spinal cord. It is designed to reduce inflammation around nerve roots where they exit the spine. It does not reach the sacroiliac joint. It does not reach the piriformis muscle. Andy had received 2 procedures that were anatomically incapable of addressing his actual pain source. And nobody had stopped to question whether the diagnosis justified the procedure. I referred Andy to a muscular seal specialist who performed a diagnostic sacroiliac joint injection both to confirm the diagnosis and to provide therapeutic relief simultaneously. The result was immediate and dramatic. Andy called my office 2 days after the procedure and said, "Dr. Michael, the pain is gone, not reduced, gone." He was in tears. After 2 years of pain, 6 weeks of physical therapy, 3 medications, and 2 ineffective epidural injections, the right procedure for the right diagnosis provided relief in 48 hours. That is the difference that diagnostic precision makes. And that is what I want every senior facing this decision to understand before they proceed. So let us go through each type of nerve block used for sciatica in detail, because understanding what each one does and when it is and is not appropriate is the foundation of being an informed patient. The first and most commonly performed is the epidural steroid injection, or ESI. In this procedure, a needle is guided under fluoroscopic or CT imaging into the epidural space, the space between the spinal cord and the outer membrane surrounding it. A combination of corticosteroid and local anesthetic is injected into this space. The steroid reduces inflammation around irritated nerve roots, and the local anesthetic provides immediate but temporary pain relief. Epidural steroid injections are most effective for sciatica caused by disc herniation pressing on a nerve root, particularly when the herniation is relatively recent and the primary mechanism of pain is chemical inflammation around the nerve rather than mechanical compression. They are significantly less effective for sciatica caused by spinal stenosis where the canal narrowing is structural and mechanical, and they have very limited effectiveness for sacroiliac joint or piriformis-related sciatica. Research shows that epidural steroid injections provide meaningful short-term relief in approximately 50 to 70% of appropriately selected patients. But the relief typically lasts 6 weeks to 3 months and does not address the underlying structural cause. Most guidelines recommend a maximum of 3 epidural steroid injections per year due to the cumulative effects of corticosteroids on bone density, immune function, blood sugar regulation, and adrenal function. The second type is the selective nerve root block, or SNRB. Unlike an epidural injection which deposits medication broadly into the epidural space, a selective nerve root block targets one specific nerve root at the precise level where it exits the spinal canal. This makes it both a diagnostic tool confirming which specific nerve root is the pain generator and a therapeutic tool for reducing inflammation at that exact location. Selective nerve root blocks are particularly valuable when the imaging findings show abnormalities at multiple levels, and it is not clear which level is actually causing the symptoms. They are also useful when a patient has had an inadequate response to epidural injections, because the more targeted delivery can sometimes achieve results that a broader epidural injection could not. The risks are similar to epidural injections, but the precision of the needle placement makes this a technically more demanding procedure that should only be performed by an experienced interventional specialist using real-time imaging guidance. The third type is the facet joint injection, also called a zygaphyseal joint injection. Your facet joints are the small paired joints on the back of your spine at each vertebral level. They guide and limit spinal movement and are a very common source of low back pain and referred pain that can travel into the buttock and upper leg in a pattern that mimics sciatica. When facet joint arthritis is the primary pain generator, a facet joint injection deposits corticosteroid directly into the joint capsule to reduce inflammation. This procedure is most appropriate when the sciatica pattern is more diffuse rather than following a precise dermatal distribution, when the pain is worse with extension and rotation of the spine, and when imaging shows significant facet joint degeneration. A related procedure called a medial branch block targets the small nerves that supply the facet joints. And if a medial branch block provides significant temporary relief, it confirms that radiofrequency ablation of those nerves may provide more lasting benefit. The fourth type is the sacroiliac joint injection, which is exactly what helped Andy so dramatically. The sacroiliac joints connect the base of your spine to your pelvis on each side. Sacroiliac joint dysfunction is responsible for approximately 15 to 25% of all chronic lower back and sciatica type pain, making it one of the most common and most commonly missed causes. The pain pattern of sacroiliac joint dysfunction typically includes lower back pain just above the buttock, pain in the buttock itself, and referred pain that travels down the back of the thigh and sometimes into the calf, a pattern that is almost indistinguishable from discreated sciatica without careful clinical examination. A diagnostic and therapeutic sacroiliac joint injection deposits corticosteroid into the joint under imaging guidance. As with Andy, the diagnostic value is enormous. If the injection provides significant relief, it confirms the sacroiliac joint as the pain source and guides the entire subsequent treatment strategy. The fifth type is the puripiferous injection. The puripiferous is a small muscle deep in the buttock that the sciatic nerve passes through or directly beneath. When the piripiforous muscle becomes tight, inflamed, or spasmomed, it can compress the sciatic nerve directly, a condition known as piriformis syndrome. This typically produces a deep buttock pain with radiation down the leg that is worsened by prolonged sitting and by activities that involve hip rotation. A puripiferous injection deposits corticosteroid and local anesthetic directly into the puripiferous muscle under ultrasound or fluoroscopic guidance. It is specifically indicated when clinical examination and imaging suggest puripiforous involvement rather than spinal pathology. Botulinum toxin injections into the puripiforous have also shown promising results for cases where repeated corticosteroid injections provide only temporary relief. Now let me talk about the real risks of nerve block procedures, because every senior deserves to understand these clearly before consenting to any injection near their spine. The most common risks across all types include temporary pain flare at the injection site lasting 1 to 3 days, temporary worsening of nerve symptoms in the first 24 to 48 hours as the local anesthetic wears off before the steroid takes effect, headache from inadvertent dural puncture and infection, which while rare is a serious concern for any injection near the spinal cord. For procedures involving corticosteroids specifically, the cumulative risks with repeated injections include suppression of the adrenal axis, reduction in bone density, particularly concerning for seniors who may already have osteopenia or osteoporosis, elevation of blood sugar that can be significant and prolonged in diabetic patients, and weakening of connective tissues around the injection site. These risks are manageable when injections are spaced appropriately and when the total number per year is limited, but they accumulate meaningfully with repeated procedures. This is why confirming the correct diagnosis before the first injection is so important. Every unnecessary injection is not just ineffective, it is a cumulative risk exposure without benefit. The critical questions I want you to ask your doctor before agreeing to any nerve block procedure are these. What is the specific diagnosis that indicates this particular type of injection for me? What is the evidence that my imaging and clinical examinations support this diagnosis rather than an alternative cause? What is the realistic expected duration of relief from this procedure for my specific condition? What are the alternatives if this injection does not provide adequate relief? How many of these procedures have you performed, and what imaging guidance do you use? And if I have already had 1 or 2 injections of this type without adequate response, why do you believe a third will produce a different outcome? These are not adversarial questions. They are the questions of an informed patient who understands that the quality of the answer will tell you everything you need to know about whether you are in the right hands for the right procedure. You do not have to be on that conveyor belt that Andy described. You do not have to keep receiving the same procedure and hoping for a different result. You have the right to a precise diagnosis and a procedure that is specifically matched to that diagnosis. Andy got that, and it changed everything for him in 48 hours after 2 years of suffering. And now you have the knowledge to advocate for the same. If this video helped you today, please share it with someone you love who is facing a nerve block decision for sciatica, because this information could genuinely help them avoid unnecessary procedures and find the one that will actually work for their specific situation. And right now, drop a comment below and tell me your age and your city, and let me know if you have been recommended a nerve block for your sciatica. I read every single comment, and if you have not subscribed yet, please hit that subscribe button right now, because next week I'm going to reveal the one diagnostic test that most sciatica patients are never given that identifies the true pain source with far greater precision than a standard MRI. And that could change your entire treatment path, and you absolutely cannot afford to miss that. Your pain deserves a precise answer. Your body deserves the right treatment, and now you have everything you need to make sure that happens. Take care of yourself, and I will see you in the next